Good morning, everyone, and welcome to the second day of the third annual Neuro-Oncology Symposium. My name is Zayan Alidina, a medical student at the Aga Khan University and a part of the student organizing committee for 3 NOs. It is my honor to introduce the chair for this session, Dr. Uzma Imam, and the co-chair for this session, Dr. Shayan Sirat. Dr. Uzma Imam is the head of the Department of Pediatric Oncology at the National Institute of Child Health, and she is a member of the International Society of Pediatric Oncology and Executive Committee of Pakistan Society of Pediatric Oncology. Her research interest includes lymphomas, retinoblastomas, and brain tumors. Dr. Shayan Sirat is the assistant of clinical radiology for the Aga Khan University Hospital. Some of her research interests includes clinical imaging and oncological imaging. It is with great honor I would like to give the floor to Dr. Uzma Imam and Dr. Shayan Sirat. Thank you.
Assalamu alaikum and a very good morning from Pakistan. I welcome you all to the 7th session of the Neuro-Oncology Conference and would like to thank all the speakers, the scientific committee, and the organizing committee for making such an exciting program and arranging this fantastic conference. So without wasting any time, let me introduce our first speaker. It is my honor and pleasure to introduce our first speaker of this session. He is a well-known iconic figure, much admired in LMIC, especially in Pakistan, Dr. Eric Buffet. As you know, we all honor and respect Dr. Buffet and consider him as a creative genius and a source of optimism in the field of neuro-oncology. He is a professor of pediatrics at the University of Toronto, Canada. He is also the Guerin Family Chair in Childhood Cancer Research and Section Head of Neuro-Oncology at the Hospital for Sick Children, Toronto. His research interests include low-grade gliomas, medulloblastomas, and malignant pediatric brain tumors. He will today present on infant brain tumor trials beyond feasibility. So over to you, Dr. Eric.
Good morning, dear colleagues and friends. I want first to express all my sympathy for what is going on in Pakistan and the result of the flooding. And we are just aware of what's going on and how much it can impact the life of your people in your country. I would like to thank you for your invitation. I'm Dr. Eric Buffet. I'm a pediatric neuro-oncologist, formerly head of the Neuro-Oncology program in Toronto, and currently in the transition phase, but still a great supporter of the development of the Pakistani neuro-oncology program, particularly the pediatric program. So my topic today is to talk about infantile brain tumors trial and what they have brought to our knowledge and where we go now. I think the first comment I will make is I cannot cover all the infantile brain tumor. You can see that there is a diversity of brain tumor in infants. It's very complex. And in addition to their complexity, their treatment is very challenging. Classically, the prognosis of brain tumor in infant has been poor due to some reluctance to use aggressive treatment in new children, and in particular due to the side effect of radiotherapy in the developing brain. Of course, we have used and we are using still chemotherapy to delay or to avoid radiotherapy, but conventional dose chemotherapy has not always been consistently effective. One of the issues when we see a child, particularly a baby with brain tumor, is what exactly is the impact of the tumor on the brain development? And what are the consequences and what are the risks associated with the treatment? So the decisions in this context are very challenging. And that's why we have a very fine line between what we call a success and a catastrophic success, where we take the decisions, we think they are right, and in the long term, we see that the outcome is terrible for the child and the family. So one of the big questions is, do we have a recipe for every patient and for every situation? Is everything written in protocol? And should we treat all infants because they have a condition that can be treatable? And I take a couple of examples. This child was 1 year old at apnea and very massive brainstem tumor. Wasn't treated and eventually died after 11 days. On autopsy, it was an ETMR. So one of the most aggressive brain tumor, and there was no treatment for this. So this is another example, 5-week-old child with a massive posterior fossa tumor. At surgery, it was very challenging, and this was a rhabdoid tumor with extensive dissemination. The decision that we made with the parents was not to treat the patient, and that's the case in 20% of the rhabdoid tumor in young children. So the question is, what have we learned over the last 3 or 4 decades? And we have learned a lot from protocol, institution review, and we have learned of what is acceptable and not acceptable. And we have learned also of success story, not always the scientific approach, but we have learned from these experiences. So when we look back in the 70s and 80s, this was the building of the foundation. In early study, and for example, medulloblastoma study or ependymoma study, children under the age of 1.5-year-old were excluded usually, but still there were some children treated, but we don't have very specific results for this subgroup. A few years later, there were some early publication, and this one is a classical example of the MOP chemotherapy, MOP used in Hodgkin disease, that has shown remarkable activity in some of the brain tumors. But then really there was a development in the late 80s of the first baby brain protocol, which all are similar design, surgery, followed by chemo and radiation at the age of 3. This was a graduation radiation. And this has remained a standard of care for many, many, many years, and still today in some place, unfortunately. And that's a baby POC1, where the duration of chemotherapy was according to the age of the patient at the time of diagnosis, and all diagnoses were involved in this context, except for the low-grade glioma. And the radiation was started at the age of 3, according to the original condition, original diagnosis, and according also to the extent of the disease. And there were results that were provided showing that the outcome was a bit better when the children were older at the time of diagnosis. And the outcome was variable according to the initial diagnosis, for example, better for ependymoma, slightly better, but eventually just moving down, better for high-grade glioma, and lower for SPNET, and in between for medulloblastoma. And in terms of overall survival, there was also some difference because a number of kids were salvaged with radiation. See that Ependymoma had the best survival, and medulloblastoma was in the middle, and still PNET were just the low. There was also some evidence that patients who had a complete resection and a localized tumor were doing better. And so that's what we learned from this early protocol. The median time to progression is often short. The survival rate are lower compared to older children who are treated with upfront radiation in most cases. And the best results are in children with localized disease and resection. But there was also this evidence from parents who refused radiation, but several children who did not receive radiation were long-term survivors. And this was not science. This was the parents' decision. And what about radiation? We learned also, and that's a paper from Dr. Gajar from St. Jude, who showed that when we treat patients, this infant with radiation, particularly medulloblastoma patients with craniosspinal radiation, we have long-term survival, but there is a cost to this. And in this study, the IQ 5 years after the initial treatment with craniosspinal radiation, when craniosspinal was used as a channel, a salvage, or as an adjuvant treatment following completion of chemotherapy, the average IQ was 62. which is not a great success. So what was the next step? In this context, the next generation of protocol had an aim to avoid or delay radiation as much as possible. So this was the baby POC2, which tried to investigate whether more intensive chemotherapy was effective, and this was a negative trial, and a number of European and North American trials. And that's an example of the protocol 9921, where the treatment was going on for a period of 18 months to 2 years. And in this context, all diagnoses were studied, and you could see that the success rate of this approach without radiation was relatively low, 16% global, and going from 8% in the PNET to 20% in the medulloblastoma patient. And then there was really this transforming publication from Germany from Dr. Rutkowski, who was mentored by Dr. Joachim Kuhl, who unfortunately passed away. But Dr. Rutkowski reported the absolutely fantastic result of this medulloblastoma protocol that was using this unusual approach with intraventricular methotrexate with a RICAM reservoir, and giving an outcome that was unexpected. Nearly 80% when patient had complete resection and non-metastatic disease, and lower result for the other patients. And what they show is also that there was a relative preserved intellectual outcome, not as best as a control group without any tumor, but much better than previous outcome seen in patients who had received radiotherapy. And what they showed also is that a subgroup of medulloblastoma had a special histology, desmoplastic, and this was associated with much better outcome. So this was confirmed by all the groups in COJ, in Europe, in many different cooperative groups, and this was really the beginning of a new era in the management of infant medulloblastoma. And in North America, in fact, in parallel to this German and European experience, some protocols were developed that were exploring alternative issues. One was the use of radiation, and this was a protocol 9934, locally and not craniospinal, because there was some evidence that most of the relapse in infant medulloblastoma treated with chemotherapy were focal relapse. This protocol was not a great success. It accrued very well. There was some issue with the cumulative dose of etoposide, but the event-free survival was 30 to 35%. Nothing that could compare to the German experience. So something was not really working with this approach, and the use of conformal radiation was not really a success. There was another option that was looked at, which was the use of high-dose chemotherapy, and this was a 99703, where this trial was a phase 1 trying to escalate the dose of thyrotepa progressively with 3 courses of induction and 3 courses of high-dose chemotherapy. And the results were provided, and you can see with the arrow that's the result of the medulloblastoma. That was spectacular. Unfortunately, we did not have specific data on whether some of the patients had received radiation, so it was unclear whether this was the result of the high dose and the result of the combination of high dose and radiation. Interestingly, so there was an additional study that was done in patients who were not part of the protocol but treated according to 99703, showing that when you look at the subgroup, you can see that patients with sonic adjuvant medulloblastoma were doing much better than the group 3, very few group 4, and whether it's event-free or overall survival. And so this was a very strong message and correlation with the desmoplastic and sonic adjuvant, which are essentially the same group of patients. And there were other protocols that were developed eventually. One of the questions was the role of methotrexate in medulloblastoma. And this was the purpose of this protocol, ACNS 0334, that looked at a randomized comparison of no methotrexate versus methotrexate and showed that the addition of methotrexate in group 3 patients was associated with a better outcome. We are still waiting for the publication of this protocol, so the results are still preliminary, and I will not comment extensively on this. There was a St. Jude Young Children Study 07 that was published recently in different paper. That was a complex protocol that taking into account the risk of the patient, the histology, and considering a maintenance treatment according to the type of disease. And so this was an interesting approach because for the first time there was a use of a sort of targeted treatment. Unfortunately, the results when it relates to medulloblastoma were not really great compared to the German again, but there was some evidence that the stratification in 2 groups was, in 3 groups, was appropriate because we see that the outcome was really dependent of the subgroup where the children were belonging to. And when we look at the correlation with histology, we can see that there was also a very clear correlation between desmoplastic, classic, and large cell nanoplastic. Now, a bit lower when we look at the data from the German. And so this raised a number of questions, and this led to some molecular study. And the beauty of this study, this St. Jude protocol, is it allows the identification of 2 subgroups in the desmoplastic category of sonic edge of 1 and sonic edge of 2. And interestingly, when we look at the survival of the event-free and the overall survival of these 2 groups, we can see that the sonic edge of 1 is associated with a much more aggressive behavior. Whether we can implement this in practice is a bit challenging because these techniques are sophisticated and not immunohistochemistry. So this is still something which is looked at, but maybe a potential protocol or approach for the future. Interestingly, so this was also seen in a COJ study called ACNS 0121. And in this protocol, we saw also a number of early relapses just after the end of the treatment. The purpose was to use the same protocol that the German, but without intramonticular methotrexate. And in this experience, we also see that sonic edge of 1 medulloblastoma are doing poorly, but we also see that patients with medulloblastoma with extreme nodularity or the baby under the age of 12 months were doing very, very well. And I want to show you this slide. I'm not sure that I'm able to do it, but this is about a child who is, you can see, who was treated with this protocol and with a long-term survivor, and you don't see any difference between this child and any other child in the community. So this is really what we are aiming at. So what's going on in medulloblastoma currently? There is no COJ study, no PBTC trial. There is one consortium study with Head Start. In Europe, nothing. So people are brainstorming and trying to digest the avalanche of information that came from the different horizon research. And we are trying to develop some protocol that will eventually help with the next generation of study. Quickly, in Ependymoma, not the same approach. We have learned a lot, but from protocol that we should abandon the chemotherapy approach as an upfront treatment. And this is the experience of Dr. Merchant, published nearly 20 years ago, that show that you can irradiate infants with medulloblastoma. The result compared very favorably with the result of the chemotherapy and the radiation approach. And when we look at the IQ of this patient, it's relatively preserved, in fact, and regardless as whether they are irradiated when they are young or not. So that's a very important message, but in this context, there was a use of very focalized conformal radiation technique. A few words about high-grade glioma in infant, because also that's a lesson from protocol and from the result of molecular and biological study. The baby POG was the first just to point out that, when these patients were treated with chemotherapy only, there were 18 patients here, some had spinal dissemination, and the progression-free survival was unexpected, 43% and 50% overall survival. But also in this context, some parents refused radiation and patients survived. And really, there were a number of factors that were identified and associated with the predicting outcome. And I had some patient, that's an illustration of a child, Alexander, that I treated 22 years ago and is now an adult and doing very well. So that's an illustration. What was the explanation here? So the explanation is that, you have some alteration that are specific of infantile glioma, and this has been shown in some study in Toronto, in some study in the UK by Chris Jones, and showing that you have some alteration ALK, ROS1, NTRK, and MET that are predominantly enriched in high-grade glioma in infants. And when you look at the distribution, ALK is the most frequent, and it's also correlated with the outcome where ROS1 is a bad alteration. And with this, there are a number of drugs, in fact, that we can use to target this alteration. And that's a new future for this high-grade glioma in infants. And they have now a number of examples that suggest that we can successfully treat these patients. Some publication that I'm happy to share, a recent publication from Dr. Gajar on lorlatinib in ALK fused patients. And there are other infantile tumors, and I say I cannot go over all the different, but really the same trend is observed. There are development of specific protocol, integration of molecular biology and targeting. The main challenge is when we dissect like this is a small number of patients and the need for international collaboration. But one of the questions today is, what about low and middle income countries? There are a number of issues: access to targeted treatment, access to high-dose chemotherapy, or timely access to modern radiotherapy services. So we have to work together to make this happen and to figure out how we can make a change also in countries where there are so many kids who need treatment. It's coming, and that's an example of the collaboration between the industry, Roche, and a different partner, St. Jude and SickKids, where we are developing, a protocol for children with NTRK and ROS1 alteration, and targeting a number of low and middle income countries that will participate in this trial. And that's really very exciting, and this includes Pakistan. So as a conclusion, I would say there are significant changes that have been seen over the last 20 years, from chemotherapy to delayed radiation to integration of focal stereotactic radiation in selected tumor, for example, Ependymoma, from universal protocol to disease-specific protocol, and also some specific indication for high-dose chemotherapy. I would need more time to explain about this, but the increasing role of new prognostic factor and molecular biology in the management of this condition. So I want to share with you this picture. So this girl was 4 years old. She was 1 year old when she was diagnosed. The picture was taken when she was 4 years old. She's now 23. She has a full-time job. She was treated with a relatively, innovative approach, high-dose chemotherapy, focal radiation for metastatic neuroblastoma. Unfortunately, she's doing very well. So this is what we would like to achieve for our patient. And so this is what we are trying to do together, collaboratively, internationally, for children and infants with brain tumor. I thank you very much for your attention.
Thank you, Dr. Eric, for your enlightening talk and sharing your experience over a decade. I'm sure it has great future implications. We as beginners have plenty to learn from your experience. We would now move on to our next eminent speaker, Dr. Zubair Tahir. I'm happy to introduce him. He is a consultant pediatric neurosurgeon at the Great Ormond Street Hospital, London. Mr. Tahir possesses experience in the management of spinal issues and performing minimally invasive epilepsy surgery. Apart from clinical work, he is also an active researcher and has published articles on several pertinent topics, including the surgical management of epilepsy and head trauma in the pediatric population. He will be talking about the surgical aspects of pediatric spinal cord tumors. Over to you, Dr. Tahir.
Morning, everyone, and thank you very much for this opportunity. And I want to congratulate Dr. Inam and his team for arranging this meeting. So I will quickly talk about surgical aspects of pediatric spinal cord tumors. As you all know, this is a broad topic, and in order to do the justice, I will primarily focus on intramedullary spinal cord tumors in children. So in terms of how to classify these tumors and make a management strategy, we can divide them on the basis of their anatomical locations. And there are three main compartments. There are tumors who primarily involve extradural spaces, and these can be paraspinal tumors with involvement of the dura or spinal column. And then we have got tumors who reside within the intradural compartment, and examples are schwannomas, neurofibromas, and inclusion cysts. For today, I will focus on intramedullary spinal cord tumors in children, and these are four main types which we deal commonly in our practice. So the astrocytoma is the most common tumor, and we all know they arise from malformed astrocytes. They in fact share their pathology with their intracranial counterparts, like pilocytics, low-grade astrocytomas, anaplastics, and high-grade. In children, they are commonly located in cervical and thoracic spinal cord, and they are usually eccentric, and when we compare it with their counterparts like gangliogliomas or ependymomas. Ganglioglioma are the second most commonest intramedullary spinal cord tumors. They are formed by a neural and glial component. They are commonly located in cervical and thoracic part of the spinal cord. They are low grade and chronic slow-growing tumors, and often we see they lead to the deformation of the surrounding bony canal. Ependymoma, they arise from the central lining of the spinal cord or ependymal cells. They have often got caping cysts on the cranial or caudal aspect of these tumors, and they comprises 10% of intramedullary spinal cord tumors. And the other possibilities, differential tumors, which include in this category are hemangioblastomas and other certain tumors. So in terms of their presentation, one has to be mindful of children where these tumors can easily be missed. For example, toddlers who are trying to learn how to walk, their motor deficits can be missed as slightly delayed milestones. Pain is another common symptom. And again, small children, they are unable to communicate, and often they are irritable. So it is a key to make sure that if there is any delay in their development milestones, along with symptoms of pain or sphincteric disturbances, they should be investigated appropriately. High cervical tumors can present with bulbar features like swallowing difficulty or breathing problems during sleep. About 30% of these intramedullary spinal cord tumors can lead to the deformity of the spinal column. So scoliosis is seen in these children as a presenting symptom. About 10% of children with intramedullary spinal cord tumor, their first presentation can be hydrocephalus. We are not entirely sure the underlying cause of hydrocephalus in intramedullary spinal cord tumors, but the theory is that especially in ependymomas. They can lead to increased protein contents in CSF and hence can present as a communicating form of hydrocephalus. The other possibility is metastatic spread, which can obstruct arachnoid villi and can lead to progressive ventriculomegaly. So whenever we see a child with communicating type of hydrocephalus and there's no obstructive cause seen, it is important to image the spinal cord as well. Now, in terms of management of these children, as we all know, this has to be multidisciplinary, and these cases should be discussed in oncology MDTs. As a pediatric neurosurgeon, we play a vital part because the mainstay of the management remains gross total resection. There are a few aspects which I would like to touch upon. And one of them is role of intraoperative neuromonitoring. In fact, if we look at the recent success in terms of extent of resection in intramedullary spinal cord tumors, that goes hand in hand with our progress and understanding of intraoperative neuromonitoring. Ultrasound is a very important adjunct. Once we have done the bone work and we are about to open the dura, perioperative ultrasound scan to assess that one has done their bony work completely is extremely important. What we don't want to do is start opening the dura for the tumor resection just to realize that our exposure is deficient. And there is debate about debulking versus resection and which are the tumors which are amenable to gross total resection. And I will touch upon that as well. What is the role for performing neuroplasty in intramedullary spinal cord tumors, and whether one should do laminectomies, which means removing the posterior elements of the spinal column, spinous processes, and lamina, or put laminae back in form of laminoplasty, and is there any role of putting a brace? Now, traditionally, the surgeons used to monitor the functional aspect of the spinal cord during surgery with historical tests like wake-up test or Clonus test. They are no more used in clinical practice, and we now rely on our electrophysiological tests. And these are primarily assessing the sensory pathways and motor pathways in the spinal cord. Now, in order to access these intramedullary spinal cord tumor, we go through the posterior column, the dorsal column of the spinal cord. So in a way, our somatosensory evoked potentials, one can monitor them, but they are not very helpful during the resection stage of the tumor. On the other hand, it is our motor evoked potential, which will give us the guidance in terms of the function of the spinal cord. Either you can do muscle MEPs, or known as MEP, or you can monitor the D wave, which is the direct assessment of your motor pathways. Now, the MEPs, as we know, the stimulation is directly on your motor cortex, and the signals are recorded from peripheral muscles. And depending upon the location of the tumor, you can monitor upper limbs as well as lower limbs. The pathway which we monitor is corticospinal, and it is a good predictive of post-operative motor outcome. However, it is affected by the type of anesthesia, and hence patients require TIVA, total IV anesthesia, to monitor the motor MEPs. And you have to ask for it. So there is no constant background monitoring. We have to ask our neurophysiologists to perform motor stimulation in order to make sure that the corticospinal tracts are protected. In terms of D-wave, the probe is inserted epidurally just below your tumor. And similarly, the signal are initiated in motor cortex. But in terms of picking up of signals, you are not picking it from muscles. In fact, you are picking them from your corticospinal tract, just distal to your site of surgery. And hence, these D waves are resistant to anesthesia and does not rely on avoidance of muscle relaxants. However, it is slightly tricky to place the electrode and keep it in the midline, one has to secure it or suture it in the epidural space during tumor resection. So here is an example of intramedullary spinal cord tumor. We can see that this is T1 post-contrast, vividly enhancing tumor in the thoracic region. So in terms of your principles of bony work, we will approach this tumor from the back. And the question is how many levels of laminectomy or removal of lamina should be carried out. As a general rule, I will suggest go with the length of tumor and add +2. So this is where the tumor is located, and then you go a level above and a level below. Now, in terms of performing your laminoplasty, you have to remove the lamina. So it is not drilling or piecemeal removal with upcut punches, but in fact, using your craniotome, staying below the lamina and considering the attachment of ligamentum flavum, which is a ligament above the dura underneath your lamina, it is more practical to bring your craniotome from caudal to cranial direction. And once you have raised the lamina flap, then at the end of procedure, you can replace it. And in terms of fixation, one can use either sutures in small children. Here is an example where we did multi-level laminoplasty, and at the end of surgery, we replaced it and then secured it with a suture. The other option is you can use mini plates. This is a small child who presented with lower limb weakness, along with some bulbar features. MRI scan showed heterogeneously enhancing a cervicomedullary tumor with a cystic component. And this is to show that how many levels one can perform laminoplasty. Now, in this location, we had to take suboccipital bone along with all the cervical laminae. And in fact, one can reconstruct them and replace them at the end of the surgery. These are the intraoperative pictures soon after opening the dura and at the end of your tumor resection. And these are postoperative MRI images showing a gross full resection. And in terms of stability, these are flexion extension x-rays on the same child 5 years down the line. And we can see how nicely the laminoplasty flap has been incorporated with no signs of instability. This is an example how to perform multi-level laminoplasty. You can see a cervicothoracic exposure, and the craniotome is just above the dura. So you have to do a bit of bony work, remove the ligamentum flavum, make sure that the craniotome is in your epidural space, and then you zip craniotome from caudal to cranial direction on each side, and then lift the laminoplasty flap. Either one can remove it and replace or keep it hinged on the top aspect and then start with the dural opening. Now, in terms of dural opening, before we do opening of the dura, make sure that you have covered the whole of the tumor. Often these tumors are chronic, and you can come across swelling of the spinal cord as soon as you open the dura. It is advisable if there is an underlying cyst associated with intramedullary tumor, try to attack that cyst first. open the dura over the cyst, drain the cyst, and that will relieve the pressure and will help in opening the rest of the dura. I'm here also trying to demonstrate how we place our D electrode. And this is the small D electrode, which is in the epidural space in the midline. And one can steer it with the steri strips. And this will directly monitor the corticospinal tracts just below the tumor level. Now, once we have opened the dura, the key is to do a myelotomy in the midline. And there are different ways to understand where the midline is. You don't want to go through your dorsal column tracts. And the midline myelotomy, the first step is to bring your microscope and zoom in and then try to identify tipping vessels. So how we can identify a midline? One option is to anatomically look at the dorsal root entry zone on each side of the spinal cord. But we know that some of the tumors are eccentric in their presentation and they can deform your dorsal root entry zone. So hence, rely on these midline vessels which dip into the central cleft. Here is an example. And if you look, these small tiny vessels, they travel towards the midline and then they disappear. The reason they disappear is they go into the central sulcus on the posterior aspect of the spinal cord. And that is a good site or location to start your midline myelotomy. Okay, I've got two short videos. The trouble is usually they don't stream well, but I will try and see. So this is a case which myself and my colleague, Dominic Thompson, we operated on. And hopefully you can see on your screen at this stage, we are performing the dural opening, which is a standard midline durotomy. Once we have done the dural opening, we will anchor our, put some sutures and now here we are trying to open the arachnoid of the spinal cord as a separate layer. And once we have done that, here we have started our myelotomy in the midline. Often the tumors are deep-seated and you have to go further low down than expected. In terms of the blood vessels on the dorsal aspect of the spinal cord, I have to admit it is okay to gently coagulate them. And this does not lead to long-term morbidity. Here we are working in the midline sulcus, and the tumor is just visible there, and you can see how it looks different than the surrounding normal spinal cord. In this specific case, we started from the periphery, but soon realized that there is no clear-cut plan between the tumor and the spinal cord, hence most likely a case of astrocytoma. One can also lift the edge of the spinal cord, and here we have put the Liga clips to open up the myelotomy flaps, and then using CUSA to gently debulk the tumor. Considering it was astrocytoma, the gross total resection is sometimes difficult, and the surgical resection is pretty much guided by your intraoperative monitoring. This is pretty much the end where we can see that the cavity after resection. Now we are suturing the pia of the spinal cord. These are the pial sutures to sort of artificially neurulate or close the opening, myelotomy opening, followed by dural closure. And then we will place the lamini back to perform the laminoplasty, and these are the post-operative MR images. Now, this is a second case, which you will understand is different than the first one. This was a case of Ependymoma, and here you can see a cervicomedullary tumor with a cyst on the both aspect. You are seeing the T1 post-contrast and T2 MRI scans. Again, this is a view after opening of the dura. And here, these are the vessels which I spoke earlier. As you can see, they travel towards the median sulcus. You can appreciate we are opening up the cyst on the top of the spinal cord. And here, there is a junction between the tumor and the spinal cord. Now, this is ependymoma, which is usually well demarcated. And the principle here is to operate from outside and identify the junction between the normal spinal cord and the tumor. Because these tumors are centrally located and they are easily differentiated from the surrounding spinal cord. And as you work along, these are sometimes large tumors. So you carefully and gently continue to do your myelotomy. You can also see the D-electrode cable, which is attached in the epidural space. So you work along on the sides of the attachment, and the last bit is the tumor, which is attached to the ventral aspect of the spinal cord. One has to make sure to minimize the amount of bipolar coagulation anteriorly, because that can sometimes lead to thrombosis of anterior spinal artery. And the hemostasis is often skewed by gentle pressure and irrigation. Here we are lifting the tumor from its bed, slowly and gently, working in all directions, and keeping a close eye on our monitoring. And that's the end of the tumor resection. The tumor was removed as end blocks rather than piecemeal, considering which is compatible with the pathology of ependymoma. Here we are performing the PL sutures, and you can see the bilateral dorsal root entry zone coming all the way to the midline. This was followed by our dual closure. That's the pathology specimen, and these are the D waves before and at the end of the surgery. And what we are looking at is patients post-op imaging. So here, the aim was to explain the difference between ependymoma surgery and astrocytoma operation. How about neuroplasty? One word of caution is avoid performing biopsies in intramedullary spinal cord tumors. The reason is often the spinal cord can swell post-op, and that can lead to neurological deficits. So that is not a common practice to do biopsies. But if you come across swelling as a result of your debulking, the last thing you want to do is try to close the dura forcefully, and hence in those cases, expansion neuroplasty should be performed. About 30% patients with intramedullary spinal cord tumors, as I said earlier, they present with deformity, and the risk raises to 60% post-operatively. Children who are younger than 13 years of age, if the symptoms were more than 1 month, if they have got preoperative deformity, these are the children who are at high risk of post-operative deformity. It is rare to perform both resection of the tumor and fusion simultaneously, but 25% children after surgery, they can proceed with progressive deformity, which can require fixation and fusion. So to summarize my talk, the surgical resection is the main stay and the treatment for intramedullary spinal cord tumor with the intention of gross total resection. Intraoperative adjuncts like ultrasound scan and neuromonitoring is of paramount importance and should be a prerequisite. The surgical strategy depends upon underlying pathology. There is no role of radical surgery in high-grade spinal cord tumors. Long-term progression-free survival and oncological results are good. However, the spinal morbidity can be significant. Thank you, and I appreciate your attention.
Thank you, Dr. Zubair. It was very informative. Dr. Zubair was emphasizing on the importance of anatomical location, growth, and invasiveness pattern of spinal cord tumors in children before planning surgery. The third speaker of this session is Dr. Natia Isyashvili. She's a professor and chief quality officer in the Department of Radiation Oncology at Emory University School of Medicine and the co-lead of the Young Adult Cancer Survivorship Program at Emory Winship Cancer Institute in Atlanta, USA. Dr. Isyashvili also serves as the president of the Pediatric Radiation Oncology Society. Today, she will be presenting updates on radiation therapy for medulloblastoma. Welcome, Dr. Natia.
Thank you. I would like to thank organizers of this great symposium for invitation and really delighted to be amongst your esteemed speakers. Today, I'll be talking to you about updates, radiation management of medulloblastoma, radiation therapy component of medulloblastoma. I'm hoping that you can see my slides. Yeah, so again, this will be topic of our presentation, and I don't have any relevant disclosures. So goal of this talk will be to outline current evidence for the role of radiotherapy in management of average risk, high risk, and infant medulloblastoma. I'll review emerging data for medulloblastoma with the focus of novel risk stratifications, as well as advances in radiotherapy technologies. Lastly, I will review current toxicity data as it relates to radiotherapy advances. So let's start with current evidence around treatment and outcomes of average, same as standard risk medulloblastoma. When we look at current trends, it's always important to look back into history and lessons we've learned from it. From very early on, it was realized that due to high risk of dissemination, we need to address entire craniospinal axis for control and cure of medulloblastomas, and implementation of craniospinal irradiation technologies and techniques have emerged and went through quite a bit of evolution. Alongside, we've learned dose requirements, and without chemotherapy treatments used in early era, we had to go to really high doses. Craniospinal dose was as high as 36 gray or above, which was followed by posterior fossa boost to 54 to 55.8 gray. This resulted in some survival of these children. However, from early times, we've realized that these children unfortunately suffered from high degree of toxicities and very poor quality of life. This prompted our colleagues to look into alternatives. And one of the first efforts was to try to reduce radiation therapy dose, particularly craniospinal radiation portion, which was causing a majority of these toxicities. But unfortunately, this effort had failed. And as it was shown in this intergroup study published by Dr. Thomas and colleagues, radiation therapy to craniospinal axis cannot be reduced in absence of chemotherapy. Subsequently, we've had this landmark study with introduction of chemotherapy for standard risk patients, average risk patients, where radiation treatment was successfully reduced down to 23.4 gray to craniospinal axis, with the addition of concurrent vincristine as well as maintenance chemotherapy. And we've seen remarkable improvement, not only maintenance, but improvement of a survival of these children. And again, this became new standard of care for this generation. Further efforts have been made to decrease craniospinal dose even more. And this was attempted by Children's Oncology Group, and this is already published data and very well publicized, that craniospinal dose reduction, as it's shown in first randomization arm of this study, down to 18 gray, and this is for, again, all average risk patients, regardless of histologies, Unfortunately, it did not result in positive outcome. In other words, event-free survival for these patients dropped as compared to standard dose. Hence, this approach was not adopted. However, another important randomization from this study, which looked at reduction of volume of boost from full posterior fossa down to tumor bed, was successful. And as you can see from these Kaplan-Meier curves, patients had pretty much equal outcome for event-free survival and overall survival. Again, this was significant achievement from this study. So as a conclusion, current standards of care for average risk patients remain craniospinal axis irradiation. And keep in mind, these are patients who would not be considered infants. We'll talk about them separately. Again, these children would be treated with craniospinal axis radiation to reduce dose 23.4 gray only in the setting of concurrent chemotherapy use, which can be followed with conformal treatment, as it's shown here on the right-hand side with just tumor bed boost. This definitely needs to be supported more with more advanced image registration and other techniques to achieve good optimal tumor coverage and good local control. And again, it's very important to administer optimal chemotherapy, which also includes maintenance chemotherapy for these children. Moving to high-risk group, as we have known, this group is presenting with dissemination, and from the very beginning was noted to be associated with poor outcome, and early efforts have been made to incorporate chemotherapy treatments for these children. And after seeing some promising results with several agents added to craniospinal radiation, there have been several studies looking at different regimens, including this study CCG 921. I'm just bringing up as an example, which tested so-called 18-1 chemotherapy in comparison to vincristine, which did not turn out to be better regimen for these children. Subsequent studies have also looked at some studies have looked at chemotherapy pre-radiation approach. This was a German study, which again looked at utility of chemotherapy and outcome, and it was definitely observed to be associated with increased myelotoxicity from pre-radiation approach, as well as more interruptions in treatment. So this did not pan out to be as standard of care, and further efforts are definitely made to improve outcome of these high-risk patients with introduction of more intense chemotherapy regimen, like St. Jude's medulloblastoma study had shown dose intense chemotherapy followed by stem cell rescue with risk-adapted radiotherapy, which resulted in improved outcome in high-risk patients. Again, in this setting, we're looking at chemotherapy intensification and maintaining radiation therapy to high dose. Another example will be a more recently completed study, which looked at daily carboplatin use with craniospinal radiation, and comparing that with no carboplatin approach. And from recent publication, we see that only group 3 patients have shown benefit from this, while other patients did not have any appreciable benefit from daily carboplatin with craniospinal radiation. So to summarize, as it stands with radiation component of management of high-risk patients, we are maintaining a high craniospinal dose. Unfortunately, this still is required for these patients, going to full 36 grain, in some cases even higher dose when we have gross disseminated disease, followed by full posterior fossa boost. In this case, is still maintained as standard of care. These patients definitely are receiving concurrent as well as adjuvant chemotherapy. And as I've shown several examples in chemotherapy intensification is current approach to improve outcome of these patients. I will briefly touch on infant medulloblastoma since Dr. Buffet had outlined this topic so well. And just to, again, emphasize importance of withholding radiation treatment for these very young children for major toxicity reasons. As we've heard, this effort was made early on with introduction of chemotherapy based treatments and delaying radiation treatment to up to age 3. As you have seen this graph already with particular focus on medulloblastoma, patients' survival is definitely not as good as what we can achieve with craniospinal treatments in this case, but still possible with, again, chemotherapy-based approach. We already heard about this study. Again, I'm not going to dwell too much on this. Is Dr. Rutkowski's publication with methotrexate based approach where radiation treatment was eliminated for these patients, and it resulted not only in good outcome, particularly with patients with no residual tumors, as is shown here, but also very good preservation of their neurocognitive function, was little lower than healthy controls, but much higher than what would have been seen in patients receiving radiation treatment. And this was despite of seeing some leukoencephalopathy with use of methotrexate. So current approaches are, again, going in more chemotherapy direction, and these efforts are, again, ongoing with what we've heard. Hopefully will be more protocols designed in near future. And as it stands, radiation therapy definitely is used more as a salvage option or in focal fashion or at the discretion of physicians. Again, this is not a uniform approach when it comes to infants, but main focus is there to reduce toxicities. We definitely need to look at some recent breakthroughs in understanding of this disease and this molecular risk stratification, which many of you are very well aware. I'm not going to spend too much time on each subtype, but just to point out, several studies have shown this Wnt pathway patients, as it's shown on graphs on the right-hand side in blue color. You see like much better outcome of these patients compared to other subgroups, and there is definitely interest and ongoing effort to reduce treatment intensity, particularly de-escalation of radiation therapy for this particular group. And again, this approach is still under investigation and definitely need to be used only in experimental setting. I would like to focus more about technology development, which is obviously a more direct area of my specialty. And many of you colleagues who are not radiation oncologists have been hearing of so-called highly conformal techniques, which implies that dose we prescribe to targets, in this case, as you can see, full craniospinal axis of the child, which includes whole brain and entire thecal sac, basically down to entire spinal canal. This dose coverage, again, in most tight, most conformal fashion, can definitely preserve organs nearby, particularly visceral organs in the thorax and abdomen. In head and neck area, we can also preserve those. And also this can affect final boost portion of this treatment, which can help us at least to some degree reduce dose to areas of the brain responsible for cognition and other vital functions. Here I'm showing you an example of so-called arc-based approach, when radiation beam is contiguously circling the target and it's modulated with modern machines, allowing this changing beam fluence, and so-called volumetrically adapted radiotherapy and tomotherapy. They're both comparable techniques, as shown on the left-hand side, can result in pretty tight coverage of prescribed dose, as it's shown in the red color, and a limited amount of exit dose, or which is low dose amount typically that can reach unintended tissue. In comparison, on the right-hand side, you see a plan which is designed with use of particle beam proton therapy in this case, and this is also in current state can be modulated further shaped around target. And as you see, there is very homogeneous target coverage of brain and spine, and pretty much zero dose reaching beyond the target, particularly in abdomen and thorax and pelvis, as well as head and neck area. And again, every little bit sparing of these normal tissues help these young children with long-term toxicities. If we look further, based on some of the organs at risk, and look at these two methods, again, many centers, including ours, are now equipped with all these technologies, and we've been interested, like many others have published, how those coverage can be different between volumetrically or otherwise modulated treatments, so-called IMRT or VMED, comparing proton, treatment plans. And as you can see for this medulloblastoma case, which is modeled on 6-year-old child with standard risk features, craniospinal dose 23.4 and tumor bed to 55.8 gray. There is significant reduction of heart dose, as you see, from 12 gray to 0.6 gray when proton therapy is used, and some reduction also can be achieved in hippocampi and cochlea. Dose, as you can see in this case, was not necessarily reduced, but this is again important to be looked at for all organs at risk. But overall, when you look at the summation of these organs, proton plans typically would outperform photon-based plans. So what does it mean for us? And patients we treat, obviously, as I've mentioned, they definitely suffer from this late sequelae, late effects of radiation treatment, which has been one of the biggest challenge for managing medulloblastoma. And this late effects, is I've shown you a list of some of the major ones here, is pretty extensive, and degree of the side effects are very substantial, and quality of these children, quality of life is not optimal. I just want to bring some of the recent publications we're seeing, and with focus on modern technologies, in this case, proton therapy. Again, it's not readily available at this point, but just to understand where this is heading with some of the data we're seeing emerging from proton therapy use. So this is one of the publications recently produced by a group from Harvard, where young children with medulloblastoma and other brain tumors are treated with focal as well as craniospinal approach. And as you can see, these groups have been divided by age, less than 6 or more than equal 6-year-old, as well as craniospinal versus focal. And it's not surprising that kids who are older than 6 and treated with focal radiation only, they have pretty much maintenance of full-scale IQ, as it's shown in this green graph. In comparison, kids who are younger than 6, even with focal field, have little decline, not again as bad as what we have seen and just heard from Dr. Buffet. Some of the studies have shown as bad as 60 IQ points, and you typically 85 and above. This is still these are relatively well-functioning kids, and again these drops are pretty appreciable, especially for less than 6-year-olds with CSI, but still not reaching the levels what we have seen historically. Again, this is promising data. Hopefully will withhold with long-term follow-up. As you see, this was 5-year follow-up study. Similarly, groups have been interested also to look at comparison between proton therapy and X-ray therapy treatments. And this is actually an important study because these are relatively contemporary cohorts. They've been comparing this MD Anderson group had looked at, and as you can see, it's not definitely the case for protons to be absolute gain. As you can see in some domains, like it's shown here, children are still struggling and outcomes are almost similar with X-ray based treatments. However, with certain domains like global IQ, perceptual reasoning, and working memory, there is some good trend for protons, like patients treated with proton therapy having better performance. But again, this difference is not necessarily striking, but at least showing some promising trends. When we look at quality of life of these children, Harvard group again produced pretty nice data. This publication compares patients treated with protons here in black columns compared with healthy cohort in white columns and X-ray therapy-based cohorts, and it's pretty obvious some difference we're seeing with proton patients still have some decline in quality of life scores compared to healthy control. However, definitely performing better compared to X-ray cohort. Again, this would be considered as still very promising result. And if you look below by disease types, in some cases, more focal point therapy, there will be better preservation of these outcomes. But actually, medioblastoma group, as it's shown here, it's also actually favorably looking compared to historical data we have seen in these children. I will briefly touch on endocrine outcomes. This is actually our own publication with Harvard group jointly when we looked at our cohort of X-ray treated patients comparing with proton therapy, showing some improvement with proton therapy patients, more significant with hypothyroidism, which is not surprising from sparing thyroid gland almost entirely from dose exposure, but also some benefit in avoiding sex hormone deficiency, as well as overall endocrine replacement therapy need was decreased in these patients treated with protons. Other data also interesting to demonstrate concerns second malignancy risk, which we know is one of the biggest problems with radiation therapy, especially long term. And as it's shown here, patients treated with proton therapy, which are these open squares and triangles, would have decreased risk, lifetime absolute risk, as compared to X-ray treated patients, which are shown in solid squares and triangles. And cardiac mortality, also not surprising. This is actually even bigger difference in between proton and photon patients with, as I've shown you, significant reduction to negligible dose pretty much for patients treated with proton therapy approach. So to summarize this talk, as I've shown to you, medioblastoma treatments have evolved significantly over the course of past 2 to 3 decades. And I did not give you specific examples, but better imaging is definitely driving both initial diagnostic and staging approach, as well as radiotherapy, has definitely improved based on better imaging, which gives us image guidance and better targeting. We have been hearing about better surgery techniques, which also result in optimal safe resection of these tumors. But incorporation of chemotherapy, as I have demonstrated to you, has been one of the biggest breakthrough for these treatments, which allowed reduction of radiation treatment dose and volumes for average risk patients, as well as reduction of use of radiation therapy altogether for infants and young children. Improvement in technologies, as I have shown to you, by switching to more conformal techniques, including X-ray based conformal treatments, can allow significant dose reduction to organs at risk, which ultimately will have significance on toxicity outcomes, which are still our major clinical challenges for these children. And we hope to see more and more benefits arising from utilization of modern technologies on the radiotherapy end. And further emergence of further data, particularly with molecular stratification, can result in refinement of the therapies and potential for further de-escalation of radiation therapy intensities for these children. I would like to thank all of you for attention, and I hope to be able to answer your questions after this talk. Thank you.
Thank you, Dr. Nathia, for sharing a wonderful experience of yours. And I must say, it is a great team effort at your end to improve treatment guidelines in children suffering from medulloblastoma and enhancing the standard of care. So we will move on to the final and salient talk of the session by Dr. Amar Gajjar. I would like to introduce him. Dr. Amar Gajjar is the Neuro-Oncology Director at St. Jude's Children's Research Hospital, the Chair of Pediatric Medicine, and the Scott and Tracy Hamilton Endowed Chair in Brain Tumor Research. He is also co-leader of the Neurobiology and Brain Tumor Program at St. Jude's Children's Research Hospital in Memphis, Tennessee. Dr. Gajjar has co-authored over 280 papers, many of which have contributed to the improved clinical care of children with medulloblastoma and other pediatric brain tumors. He will be speaking about practical translation of molecular classification in pediatric neuro-oncology. Over to you, Dr. Gajjar.
Again, thank you to the organizers and particularly Noreen for inviting me to speak at this conference. So what I'd like to do over the next 15, 20 minutes is really put in context, how do you take this rapidly growing information in pediatric neuro-oncology, which is really transforming how we think about these tumors, but how do we apply it globally, and particularly as far as this conference is concerned, in low and middle income countries? Because I think that's the crux of what you guys need help with and understanding. There's several talks I've listened to, some fantastic surgery talks, targeted therapy talks, radiation therapy. So there are several fields which ultimately lead to improvement in therapy. So we'll begin with medulloblastoma. This was a single disease entity till about 12 or 14 years ago. And the first paper, which came out in 2006, suggested that there were 3, possible 5 subtypes. But now we've sort of consolidated into the 4 major subgroups: Wnt, sonic hedgehog, group 3, and group 4. And now what is emerging is the subgroup and subtype within the subgroups. And I think the most stable classification is sonic hedgehog with the 4 subgroups, the alpha and the delta, which is the children and in adults, and then the infants with the sonic hedgehog beta and gamma. You have the group 3 and group 4, which in this classification is subgrouped into 3 individual subgroups, but there's further data now showing that they may be within the group 3 and group 4. If you lump them, there are 8 subgroups. So this is driving everybody crazy, and people are thinking, how the heck am I going to treat medulloblastoma? So I think the key questions are the importance of gross total resection compared to maximum secure total resection in the posterior fossa. We don't have any fancy molecular classification. So the previous standard risk method for classification is still valid for us in treating medullo. What is the best approach for unstaged medullo? Do you upstage or give a higher dose of radiation? Recommendations for ideal chemotherapy for medulloblastoma, and should we use autologous stem cell rescue for medullo? So those were the questions that were posed at one of the conferences that I spoke with. So currently, if you think about treatment of medulloblastoma, the key thing is trying to get a good surgical resection. And by that, I mean trying to get the tumor down to a minimal dose, minimal tumor volume. The next stage is to really get a very good staging done. And that involves the extent of resection, the metastatic status, which is done by imaging, and then CSF cytology, which is a lumbar CSF cytology, which is obtained 10 to 14 days after surgery, histological classification, and then FISH if available. Using histology, immunohistochemistry, and FISH, you are almost 90-95% of the way there without any expensive molecular testing. So using this, you can get sort of three groups of tumors. You have the low-risk tumors, which are gross totally resected, M0, non-metastatic, classic histology. That's a low-risk group. If you add monosomy 6 and nuclear beta-catenin, you get the Wnt subgroup. And these are the patients you can treat, the Wnt subgroup, particularly with 18 gray CSI with adjuvant chemo. Now, the chemotherapy that we use is just a 4-month chemotherapy, simple cyclophosphamide, cisplatin, and vincristine. We don't need to do stem cell rescue. We use 3 grams per meter square of cyclophosphamide per cycle. So total exposure of cyclophosphamide is only 12 grams per meter square, 4 rounds of cisplatin, and 2 doses of vincristine. There's an intermediate risk group patient, which again is gross totally resected, non-metastatic, where you can treat with 23.4 gray with adjuvant chemotherapy. Again, 4 cycles of adjuvant chemotherapy is good enough. And then the high risk group of patients, which have metastatic disease, extensive lumpy disease at the primary surgery site, where you need to use high-dose CSI and adjuvant chemotherapy. So I think if you think about it this way, it simplifies. Now, if you do get methylation ultimately, or you can send the tumor tissue out for methylation, you can split and sort of further divide these treatment options. But even if you use these three sort of simple ways, I think you are doing your patients a huge favor. So again, this is an article which was published by Paul and others, and again says the same thing, takes the Wnt into average risk. The radiation therapy just now, like I mentioned in my talk at the plenary session, there are studies which are using CSI of 15 gray to 18 gray. That data should be coming out within the next year. The studies have finished accrual. For the high-risk patients, you can use higher dose radiation therapy if they're metastatic. If there's residual disease, these patients, you can give a couple of rounds of chemotherapy, and the tumor disappears. You can again treat them with lower dose craniospinal radiation therapy, and then conventional chemotherapy at the end of radiation therapy, and the outcome for these patients is excellent. Sonic hedgehog, you can split into 2 subgroups. One is an average risk group of patients, and second is a high risk group of patients. I think the key point I'd like to make over here for the high risk group of patients, in addition to the patients being metastatic disease, is they typically have MICAN amplification you can pick up by FISH, GLI amplification you can pick up by FISH, and p53 mutation, which you can pick up by immunohistochemistry. Again, without fancy advanced molecular techniques, just by simple immunohistochemistry and FISH, you can pick out the bad actors. These patients, again, you can risk stratify them, give them appropriate doses of radiation therapy and conventional chemotherapy. There are studies which are ongoing and which are going to address the question of addition of sonic hedgehog inhibitors to conventional chemotherapy, but I would not recommend this currently unless we have hard data to show that it has efficacy only in the patients which have patch mutations. So then it starts getting tricky. For your non-Wnt, non-sonic hedgehog group, again, you can split them into average risk and high risk. I mean, the bad acting high risk patients are the ones which have metastatic disease, particularly the ones which have MYC amplification. These patients do poorly, and those are the patients that we are eagerly trying to develop novel therapies to improve the cure rate. So I think this settles a broad sort of approach to treat medulloblastoma. The molecular papers will keep on exploding. There are more papers going to be coming out later this year because we're going to do a group analysis of the data that we just published last year along with the 2 Cox studies, and coming out with a integrated molecular and clinical risk stratification. But this will get you, again, 90% of the patients will be appropriately treated this way. So switching to ependymoma. Our modern thinking of ependymoma sort of splits according to the area where the tumor arises. So supratentorial ependymomas are described by patients which have the C11orf relay or the YAP1 fusion. This is common in the children. 70% of the supratentorial ependymomas have this particular fusion. In the infant, we now divide them into posterior fossa A and posterior fossa B. Most of the infants which have ependymoma have PFA tumors. So again, you don't see PFA Bs till the patients are above 8 to 10 years old. And then within the PFA, you have molecular features, which I will talk to you a little bit about, which can actually predict poor prognosis. And then you have the spinal cord ependymomas, which are myxopapillary, and again, high frequency in older patients, particularly those who have NF2 mutations, generally have a better prognosis. So again, treatment for ependymoma. This is a primarily surgical disease. I think Dr. Zubair showed how you can, with patients, do a gross total resection of the spinal cord ependymoma. I think that was a beautiful resection he demonstrated. Similarly, supratentorially and in the posterior fossa, the attempt should be gross total resection. Again, in LMICs, it's difficult to try to get gross total resection, particularly in the patients which are infants, which have CP angle tumors. Generally, if you start dissecting all the tumor out, the patients develop severe cranial nerve palsies, and it's very difficult to have the kind of supportive care, trachs and G-tubes to look after these patients. So an alternative approach that we have used very successfully is to debulk the tumor, use 2 to 4 rounds of chemotherapy, you devascularize the tumor, and your surgeon can go in, and usually at the second time he can get a gross total resection. Metastatic workup of these tumors, usually in extent of metastatic disease is less than 10%, but we must do a baseline spinal MR and the CSF cytology. The treatment for ependymoma is conformal radiation therapy to the tumor bed. If it's a localized disease, the whole question about adjuvant chemotherapy is going to be published soon in the recently concluded ACNS 0831 data, where the patients were randomized following surgical resection to get either no further therapy or adjuvant chemotherapy. And I don't want to prejudge the data. There's been a lot of rumors about the data. But I think by the next round of meetings, we will have this data for everybody to see. It looks as if right now, adjuvant chemotherapy following good, nice conformal radiation therapy did not show efficacy. But again, as I said, this was data which has been published in abstract form, was presented at ISPNO, but has not been confirmed in a publication, peer-reviewed publication. In the very young infants, I think we can give chemotherapy to hold off on radiation therapy. And again, people feel comfortable offering radiation therapy till the patients are about 18 months of age. So this is, standard treatment of ependymoma. Again, with this kind of workup, meticulous resection, and good radiation therapy, typically up to 54 gray, being careful for the CP angle tumors that you protect the upper cord, because that's an area where you can get radiation necrosis. You're going to cure 60 to 65% of these patients long-term. Early follow-up will give you 80%, but there will be late failures. And now we know the molecular patients which are going to be failing because of molecular disease. And I'm going to show you some of that data right now. So this was the previous COG study, which was published, which has treated patients with conformal radiation therapy, and the patients which had incomplete resections were given chemotherapy, second resection, and then radiation therapy. So if you look at the numbers, roughly at 5 years, as I mentioned, you can get about 60% of the patients. You follow them out longer, you cure about 55% of the patients. This is a large group of 356 patients prospectively treated on a protocol. Now, if you look at patients which have a 1Q gain, you see how the event-free survival drops to about 47.4%. And I think this is one prognostic feature that we talked about in my earlier talk that we should be introducing in staging these patients, because you can see the ones which don't have 1Q gain have an event-free, 5-year event-free survival of about 80+%. Again, if you look at the failure rate, cumulative failure rate, patients which have 1Q gain, which is the dotted line, almost 31% of the patients fail. The ones which don't have 1Q gain, roughly about 13.7% of the patients fail at 10 years. So this is a very negative prognostic feature. And then again, distant failure is higher in the patients which have 1Q gain compared to the patients which have no 1Q gain. So local and distant failure, and I'll show you more data with a larger series which has just been accepted for publication, which confirms this data. So ultra high risk ependymoma are patients which have 1Q gain and 6Q loss. This is a paper which was published or which has been accepted for publication, led by the investigators from Sick Kids in Toronto, with multiple other investigators across the globe which have contributed. So it's a large number of patients. And you can see among the 484 patients, this discovery cohort, which did not have 1Q gain, the progression-free survival is roughly 50%. With the 1Q gain in 114 patients, it's down to about 20%. And again, in the second cohort, this has been confirmed, 234 patients with 1Q balanced, we're curing about 60%. And out of the 86 patients with 1Q gain, again, you're roughly getting a cure rate of about 20%. So this is the data. This is relatively new data, but this has been confirmed in the recent COG study. Patients with 6Q loss also have a very poor prognosis. Again, this is comparing patients with balanced 6Q versus 6Q loss. The number of patients is smaller, 19 patients only, but they do very poorly. And then when you combine all of this, this is what you get. So the upper line is 1Q and 6Q balanced, roughly about 50% at about 10 years. You have 1Q gain and 6Q balanced, immediately you drop to about 20%. You have 6Q loss. Again, you're sitting down at the 10%. And if you have both 1Q gain and 6Q loss, you're sitting roughly at about 10% at 4 years. So this is picking out the bad actor patients. This is where you can really help the families make some choices, particularly when the time when these patients fail. Re-resecting and re-radiating and keep on doing this is not going to save these patients. And these patients should be put on more experimental phase 1 or phase 2 protocols when available. But again, these patients are not curable currently anywhere in the world, and particularly in low middle income countries. Identifying them upfront with a simple FISH test, we are not asking something fancy, you can really save a lot for these patients. So if you look at the pattern of failure for the balanced patients, most of the failure is local. You can have some metastatic failure. 1Q gain, the proportion of metastatic failure increases, and then you have combined local and metastatic. 6Q loss, mostly local failure. And then when you have the 1Q gain and 6Q loss, you see mostly metastatic failure. So now we've got a good molecular explanation of the patients which have metastatic failures. If you want to monitor these patients, these are the patients you want to repeat MRIs. The rest of the patients can be followed with just brain MRIs. If there's local failure, then you can do a spine MRI. Okay, so we talked about Benjulo, we talked about Ependymoma, high-grade glioma. So again, this is a complex disease which has now been really separated into different methylation patterns described by our friends in Heidelberg at the DKFZ. You have the K27 midline gliomas, which are sadly uncurable. They have a progression-free survival of 6 to 9 months. This includes DIPGs, midline thalamic gliomas. You have the G34 mutated hemispheric tumors, in addition to p53 mutation and ATRX mutation. They have a better survival. The IDH mutated gliomas, they have a much better survival. And we heard earlier at the plenary talk about targeted therapy possibly being introduced for this subgroup of tumors. You have the RTK tumors, which have the PDGFR mutation and the CDKN2A and B deletion, EGFR amplification. Again, single agent targeted therapies have not worked for these patients. And patients, particularly which have CDKN2A or N2B deletion, have a very poor prognosis. You have the mesenchymal subgroup, again, predominantly seen in the cerebral hemispheres, which have NF1 mutation, p53 mutation. Again, they have a reasonable outcome, progression-free survival between 12 to 18 months. And then the PXA-like, this is a relatively new subgroup, PXA-like tumors, which have the BRAF V600E mutation and occasionally have the CDKN2A deletion. So the patients which have the CDKN2A deletion have a poor prognosis. So this is a common topic. So if you don't have a protocol, how do you treat high-grade gliomas? Maximal surgical safe resection depends on your team, your neurosurgeon, and what safely they can resect. Again, staging to rule out metastatic disease, rare in high-grade gliomas and ependymomas, focal radiation therapy to 55 to 59 gray in patients which have localized disease. There's a question about concurrent chemotherapy where the temozolomide works, and then adjuvant chemotherapy with temozolomide or CCNU and temozolomide. Again, if the family cannot afford, this is becoming expensive, you're not going to cure the patient. Temozolomide is not a must for these groups. Randomized studies have shown in pediatrics that temozolomide really doesn't impact the outcome. In adult patients, it's pretty much the standard of care. Again, it depends on the MGMT methylation status. So this is a subgroup of patients where a lot of newer agents are being tried and will continue to be tried. But again, in LMICs, unless something is really showing efficacy or you've got access through a protocol to some novel agent, I think standard of care is as good as anything one can get. You're not going to cure these patients, unfortunately. So this was a study which was published in Lancet Oncology, which compared CCNU and temozolomide versus temozolomide alone. You can see, at a certain point, there seems to be a beneficial effect, but in the long run, at about 4 years, the curves sort of coincide. But the problem is the toxicity. So if you compare the percentage of patients with temozolomide alone versus a combination of CCNU and temozolomide, you see higher thrombocytopenia, which again becomes a clinical problem in patients which have difficult access to platelet transfusion and supportive care. So I think this is a study that I'd like to just briefly present. This is the Herbie study, which mirrored a similar adult study, which used a non-brainstem high-grade glioma, randomized phase 2 study with temozolomide and RT, and then the randomization, basically all patients got bevacizumab and some patients got temozolomide alone. You can see just by the location of the tumor, the hemispheric patients did better than the midline tumors. 47 midline tumors by 3 years, we were down to about 10%. Again, the wild-type patients with high-grade gliomas did better compared to the patients which the H3, F3A, G34RV, and the K27 mutant tumors. They do extremely poorly, and they're a hallmark. The K27 is a hallmark, molecular hallmark of midline tumors. So if you have a midline high-grade glioma, you can almost bet it will have a K27 mutation. So again, leaving high-grade gliomas and switching to pediatric low-grade gliomas. So this is an area where, again, there's a lot of new information coming and a lot of confusion between all the molecular subgroups and subtypes. You can see the distribution of low-grade gliomas in the cerebral hemisphere, in the diencephalonic region, in the cerebellum, in the brainstem, and in the spine, in the small percentage of patients which present with metastatic disease. And then you can look at the majority of the patients which have pilocytic astrocytoma or low-grade glioma, NOS, and then you can have the PXAs, the diffuse astrocytoma, oligodendroglioma, DNET, glioneural tumor, angiocentric glioma, and then the infantile ganglioglioma. I think this is a very important slide which shows what are the most common driving events in pediatric low-grade glioma. So you can see the common ones are the KIA BRAF fusion, the BRAF V600E, and the NF1 mutated patients, which account for the majority of the patients. Then you have other BRAF fusions, the RAF fusion and the KRAS SNV. Then there's a smattering of patients which have FGFR fusions. And then we have all the other receptor tyrosine kinases, ALK, RAS, NTRK, PDGFRA, PDGFRB, KIT, MET, and RET. And Dr. Buffet mentioned about infants which have the ALK, RAS, and NTRK fusions. So I think once you understand the different kind of fusions, you have the MIB and the MIB-L1, and then you also have the non-MAP kinase oncogenes, the K27 mutation, the IDH mutation, the PIK3A mutations. But I think the key thing to take in mind is likelihood of these rare mutations is small. Majority of your practice is going to be on the KIA BRAF and the BRAF V600E. And again, Dr. Batchelor mentioned about the introduction of MEK inhibitors, and I am going to now take you a little contrary route. So the whole purpose of this is how does one approach these tumors when you're in a low middle income country and you don't have all these targeted agents, which are very expensive, even for the advanced economies. If you look at our traditional data with chemotherapy, this is a very nice paper which summarizes whether you use carbovincristine, carbo, PCV carbo, again, variations, carbovincristine versus TPVC, carbovincristine temozolomide, and then again, randomization between carbovincristine and VP16. You can see the large number of patients which have been enrolled. Roughly, you can see the event-free survival for all of these is between 45 and 50% at 5 years, okay? And overall survival is roughly in the 80%. So if your back is pushed to the wall, you're not going, it's okay to begin with this kind of chemotherapy. You're not hurting the patient. You're prescribing good care, and you're not driving these families bankrupt by giving them standard chemotherapy. There are currently randomized studies which are being conducted by COG comparing the MEK inhibitor with standard chemotherapy in newly diagnosed and in recurrent setting and in patients which have NF1. That data will take time to accrue, probably 5 to 7 years from now. And I think ultimately people will switch to these MEK inhibitors, but right now, do not feel bad if you do chemotherapy. Even if you look at the patients with NF1, similarly, you can see the event-free survival with all these agents is about 10 to 15% higher, between 60 and 70%. The overall survival, again, is in the 100%. These patients really have a chronic disease, but they do survive. They hardly succumb to this. So this is a good lesson to just sort of take a step back and understand that giving standard chemotherapy is not the end of the world. And then Dr. Buffet and others have piloted the use of vinblastine and Avastin. So in patients which have got chiasmatic hypothalamic gliomas adding Avastin to the standard regimen sometimes can help you stabilize the patient much faster and reduce the size of the tumor and the enhancement, in some cases even stabilize the loss of vision and have some visual recovery. So clearly the big sort of excitement in this field has been this data with selumetinib, which has been published in Lancet Oncology by the study which was done by the Pediatric Brain Tumor Consortium. And you can see, this drug definitely has efficacy, and you can see the progression-free survival percentage in these patients. You can see the efficacy in the BRAF fusion patients, which the BRAF mutated patients. This is the first generation MEK inhibitors. These drugs this field is getting crowded. There are 5 of these now currently out there vying for space. And then second generation inhibitors, which are better brain penetrant, are also being studied and are in protocol currently, which are accruing patients. You can see the waterfall plots. You can see the patients with the BRAF fusions, is the Kia BRAF fusions. A large number of these patients have a very good response to this drug. In the recurrent low-grade glioma, again, you can see the number of patients which have progression-free survival. And again, you can see the patients which have had a very good response, with almost 50% of the patients showing PRs. So in summary, the clinical therapeutic choices are lagging behind the molecularly defined subgroups. So you are going to keep on seeing subgroup, group, and subgroup and subtype, but the targeted therapies are getting introduced in these relapse patients. But I think the take-home message, which I want to sort of really drive home, is standard therapy, surgery, radiation, chemotherapy is still very good option for these patients. Patients at high risk for disease recurrence do not have curative options, even in high-income countries. So let's go over them again. Medulloblastoma, sonic hedgehog p53 mutation, medulloblastoma group 3 with MYC amplification, Ependymoma, PFA with 1q gain and 6q loss, supratentorial ependymoma with Rayleigh and CDKN2A deletion. These are all tumors where we can't cure them. DIPGs, midline thalamic gliomas with H3K27 mutation. A lot of the PDGFRA and EGFR-driven high-grade gliomas, all of these are poor actors, and beyond standard chemotherapy right now, there's no curative approach. I think the availability of generic therapies becoming, targeted therapies becoming generic will slowly happen. I think Dr. Batchelor did a very nice review this morning about, using an mTOR inhibitor, the selumetinib data, the information for the plexiform neurofibromas, some of the IDH inhibitors, Avastin for, some of these NF2 patients which have schwannomas. There is a movement. I think we should wait carefully for the data to be published, because these are still relatively expensive therapies to be, for low middle income countries, practitioners to be introducing them into practice. There will be a movement. The drugs will get cheaper. Patients from all over the world will benefit. Pharmaceutical companies are looking at opening some of these studies to get, these are rare subgroups. They want accrual to their patients. So whenever you get an opportunity to participate in some of these studies, please do so at your centers, because that's a way of getting free access of drug to your patients. So with this, I will conclude. I hope I've sort of driven the point that there are patients you can cure, which you can define, and that's where you should be spending your, really trying to focus your attention. The bad actors, unfortunately, nobody can cure them, LMIC or high income country. And that will help you sort of divide your resources. Thank you very much. Open to questions.
Thank you, Dr. Gujjar. This is truly inspirational and practical. Applying molecular characteristics for patient management is a must. And getting targeted therapies for our patients in LMICs is a major challenge currently, but I think we must find ways to give treatment benefits of all this research to our patients. Now we'll take few quick questions for our faculty and the speakers.
Hello, excellent talks, and especially Dr. Amar Gajar, your concluding remarks were very positive and optimistic in this very nasty disease of children, especially medulloblastoma and ependymoma. I was just wondering that all the mutations you have mentioned, can you just predict, have you ever compared it with the population which has more consanguinity? Like in our country, it's different genetic profile. I presumably, I don't know, but you being a oncologist, what is your impression about that? Is there
Yeah,
any
so
disease
so
possible
one
there?
yeah, so one subgroup which I talked in my earlier talk is these patients which have constitutional mismatch repair deficiency syndrome or Lynch syndrome, which is higher in patients which have consanguineous marriage. Also, you got to be careful. Again, this is what we are learning because we are doing somatic sequencing and we are doing germline sequencing. So you're going to pick up families which have autosomal recessive characteristics which are getting passed through the germline. And in addition to Lynch syndrome, you have to think about APC germline mutation in Wnt medulloblastoma, p53 mutations, and Lee-Fraumeni syndrome, which you can see in high-grade gliomas and medulloblastomas. And there are, again, Dicer predisposition syndromes for patients which have pineal region tumors, also have pleuropulmonary blastoma, also have thyroid malignancy. So I think being aware of these, there are guidelines now being developed for monitoring these families. But also remember, in the West, people are more open to do all these studies. I think in our countries, there's a lot of social stigmata associated by doing all these extensive genomic studies, and not many families may be willing to get all this data on these patients. So there's as I said, there's an emerging field, which is, as we are studying more and more of these, there is a emerging field which will be definitely seen much more in patients which have consanguineous marriages.
So for the sake of time, we conclude this session, and I would like to thank again all the speakers and the scientific committee, organizing committee for arranging this fantastic conference. Thank you.
Thank you.